I would like to take advantage of our speakers. Very few times we have such brilliant people, Dr. Warner, Dr. Boosters, Dr. Wayne. Instead of closing remarks, let's expose them to doubt their microbiota. So as many questions as you have, I'm sorry that you'll be standing, but I'm also standing, so let's deal with it. Yes, of course, please. I don't know why you went down. The creator of the JLS.
Questions? I cannot say anything about soccer because I'm ashamed, but we are able to do something else. Dr. Jaime Ramirez, I have a question on the left side. Fernando Medina from Colombia, again. We know Colombia is the winner, but we will leave that for later. Okay, the important thing is a question I would like to have a question for Dr. Van der Plas. Felicidades por la información acerca de la microbiota. The question would be, lately we've had some research on the relationship about microbiota with the brain-intestinal axis. There have been work that has been done, all the iteration with autism, with depression. We've had some depressive bacteria also, obesity with verbicular related in the concentration. So my question would be, with all this information that we have, what can we tell our patients and how can we use in the clinical practice? Can we say it can be used for obesity? Can we use it for depression and for other related things? Just one thing, please, short, brief questions so we can take advantage of the time we have with our speakers.
Well, my personal view would be that you can only use it in these indications on which there is clinical evidence and that you have randomized controlled trials showing the efficacy. I would say if I would be sure that if I take 2 capsules of probiotics every day, I would lose 20 kilograms, I would start yesterday. But there is no evidence. Of course, you have literature is full of that, and there is absolutely also literature that there is a relation between, for instance, gastrointestinal microbiota and weight of the patient, overweight as well as marasmus. There are studies with showing, for instance, with fecal transplantation from a healthy child to a marastic child that you normalize the weight. So there is certainly something there. But now what has been shown is relation. We do not know how it works. There are no randomized controlled trials, so don't start to recommend that for your patients in all these indications for which there is today no clinical evidence. Wait until the trials come out. I don't know what my colleagues think about that. But...
Okay, ¿alguna otra pregunta? Por favor, aprovechen. Sí.
Here they are, available for you, so you can make all the questions you want.
Aquí hay muchas manos levantadas aquí. ¿Quién anda por allá? Dos micros, otro micro para acá para dividirlos, por favor.
Isaac Hassan from Venezuela. I'm going to be on the other side. If we start from the fact that we have millions and millions of microbiota inside our body, and we are having any of the things that we have mentioned as a treatment. This amount of microbiota, of probiotics that we're taking, regarding the general microbiota we have in our body, it's an infinite amount. How can we demonstrate that what we are taking, that it's 0.01 of microbiota we have, is what really producing a change? Well, we have many things to consider. It depends on the biological properties of that bacteria. And the best example is when we consider a pathogen. So we have many bacteria that have a barrier effect, and they are helping us avoid infections. But a small amount of salmonella can generate an enteromorrhagic diarrhea, and a small part that could be very, very small amount. Why? Because that pathogen is well adapted to invade something, and when it finds the place where it could really cause the damage, then it starts to cause the infection. So same could happen for other bacteria that could do something good. There are probiotics that have an effect on the immune system because they are easily stimulating toll-like receptors, and we were talking about the mechanisms of the epithelial cells, and maybe they are generating a situation of decreasing gut inflammation. It has been demonstrated for several probiotics, and that is having a clinical effect also. Or we were also talking about the effects of antibiotics. There is a study that I haven't had the time to present. We published it in PLOS ONE last year in Barcelona. And when we give a treatment with antibiotics to our patients, even though the treatment is for a respiratory infection or a urinary infection, then in feces there are different bacteria, but as the antibiotic goes there, many bacteria go there, and at the same time, there are others that increase in amount. So what we have seen that when you have a gram of feces, the density of bacteria in that gram is never decreased. When we are taking antibiotics, then we are not cleaner. We're just changing the composition of bacteria we have in our body, because some start to increase, others start to decrease. When we stop taking the antibiotic, in theory, that balance is reestablished, but sometimes it doesn't happen. There are bacteria or microorganisms that when they are in a high level, they became rich, they domain the ecosystem, and they do not allow the ones that are suppressed that could increase in amount. And we have seen this before. So for this patient, the effect is longer, and there is a lack of diversity because some bacteria are dominant. I was mentioning this because if you avoid that drop when you're having antibiotics because you are giving a probiotic, then you are putting in the ecosystem certain elements that avoid this imbalance, avoid the effect of an empty nest that others could occupy. This is an action mechanism. And what we've seen is that in the small bowel, just one intake of probiotics has an impact of 24 hours. And as the motility goes, there is a percentage of the bacteria in the small bowel. It doesn't have a stable ecosystem. It is transitory, and it is moving depending on the more complex level that we have. So we've had different studies with different patients that have had just one dose of probiotic, then we detect up to 24 hours later that they have increased more than 10% dominant flora. I think when we're talking about probiotics and microbiota, it is important to change the way we think, because we have an idea of pharmacology, so we are always thinking about the pharmacodynamics, pharmacokinetics, how a drug is working, and that is difficult to change, and it is related to the question to probiotics. So then we start having these aspects that Francisco was explaining on how we think the probiotic is acting inside the lumen of the gut, but it is very difficult to change the logic way of thinking all physicians have.
La doctora Vera de Brasil quiere hacer un comentario,
Dr.
por
Vera
favor.
from Brazil.
Y si no, ya la forzamos de hablar.
Felicitaciones a todos.
Congratulations to all the speakers. So I wanted to ask Dr. Warner that according to what we know so far,
Lo mejor hasta ahora, donador de fecal transplantation.
who could be the best fecal transplantation donor? In my unit, we started doing feces transplantation in the year 2002, and we published an animal inflammation study, and we continued to do it until 2010. But always with animal models. In 2010, we started to have the first data with human patients, and we see what we had in a sample and the different amount of virus. And back then, the medical staff of the hospital decided to do fecal transplantation in humans. Why we decided not to do it? Because each sample has a high percentage that could even be up to 80% of a fecal sample of bacteria that are not well acknowledged. That could be, this is a bacteria that is bought, talking about bacteria that is singing at a vertebrate or an invertebrate. It's very general. We are considering invertebrate insects, and for vertebrate we have different species. So we do not know everything that we find in the sample. What about the recommendations about doing fecal transplantation in patients with diarrhea? So with the staff, we decided not to do it. So there is a complex situation that is diarrhea, and it has a bacteria that has this capability that when taking antibiotics, it is a dominant opportunistic, and it is not allowing the ecosystem to recover again. It is invading the mucus. It has an effect on permeability here in the colon, and it is not allowing to have a balance. It is increasing and it's not decreasing, and it is becoming rich, very rich, and it's not allowing for the rest to become richer. So when we prescribe antibiotics, then we lose diversity of bacteria, but it is very difficult to eradicate this bacteria because he has spores, and the patient is in a situation with less diversity of bacteria, and it is dominating even more. So with this situation, there is no remedy but having diversity to eliminate these bacteria, and you can have unknown viruses, injected unknown viruses. I haven't mentioned, but we have seen that the phage every person has are unique on 1% of non-common genes. So when we've had fecal transplantation, we see that these phage are going through one another, and it's been established. There's no problem about it. But the indication of ulcerative colitis, we haven't even been able to test it. We didn't want to experiment about it because we're talking about our patients, and the rat had very good results, but our patients are not rat, and we see that we cannot risk a patient with different unknown species and different unknown viruses and unknown fate. So we made this decision in 2010, even though we had a good experience, and maybe this month in gastroenterology we will publish 2 studies, and there are two studies of feces transplantation in ulcerative colitis. That is one positive and the other one is negative. But let me tell you the difference here. The difference is that in one of the studies, placebo failed. I could tell you the figures. In one study, placebo has a response of 24% and transplantation of also 24 to 25%. This is a negative study. We did it in the Amsterdam Medical Center that I know it's a well-known center. Another study is done in McMaster's University in Canada, and it has a response in the test of 25% as the others, and placebo 5%. So the study in the good one, placebo failed evidently if we see other studies. So the McMaster study was presented last year as negative, and then the paper is published as positive. So we'll see. I see Dr. Cohen a little bit restless, that was complaining. I didn't know what he wanted to do. So you were just moving. Would you like to say something? I don't know if you had any fecal transplantation, but I feel I'm privileged to be here with these speakers. If you want me to tell you what we've done here, that is medicine applied into evidence to base our scientific activity, I would like to tell our previous speakers that the only evidence is that the current champion in America is Uruguay. Others are just assumptions, even though the rectal exploration we had for a player. So we will sleep and rest if your conscience is free of any guilt. So let's continue and enjoy this banquet of presentations. Additional questions, just 5 more minutes. I'm Dr. Sabac from the Children's Hospitals in Buenos Aires. I wanted to ask a brief question to Dr. Van der Plas based on time, and is that evidence in probiotics and allergy to breast milk. So how much have we gained and how much do we still need to research in this topic?
I would say that today there is no evidence that probiotics really decrease the development of allergic disease. There are quite a number of studies which seem to suggest that if you start probiotics during the last month of pregnancy and then continue to give it to the mother if she's breastfeeding or to the infant, that may have a preventive effect. All the studies with probiotics, where the probiotics were started after birth, are to my knowledge negative. So there is no active recommendation today to use probiotics in the prevention of the development of allergic disease.
Okay, you're going 3 minutes before. I'm asking you to be back 5 minutes to start the workshops. You have 1 minute, short question, and let's go to lunch because we are hungry. I'm Dr. Pablo Cáceres from Honduras, and I have a question for Dr. Warner. The management for patients with autism, it's a very complex management that requires different services, but there are different recommendations and studies that have talked about the management of microbiota in autistic patients, diet too, and they've also considered if it's necessary to eliminate gluten or dairy products. And what are your recommendations about this? And we've heard that it is associated to the presence of the panda syndrome and streptococcus associated to neuropsychiatrist syndrome. So what do you think about changing a diet in autistic patients? Is there a general recommendation, or what can we say about that? Well, this is a topic that is not in my field of expertise, but we have worked with a center in Panama who is studying microbiota in autistic patients. And they sent us samples to do the sequenciation through the sequence. And they had a high prevalence in like 20 children. It hasn't been published yet. I would say that from the 20 patients, maybe 16 had intestinal injuries. And the microbiota, we had low diversity of species and excess of protobacteria that are sporphidomonas, that are bacteria that are linked to problems with teeth, enterobacteria, where we have Klebsiella, Escherichia coli. These bacteria are oxygen resistant and have an additional capability of sticking to the wall. So what we see is that with these children also had different scores. There are autistic patients that when they eat, there is a nervous crisis. I don't have any personal experience, but some start to get nervous. They start to hit the walls, and that's why they have dietary changes. But with these children that have these pain reactions after they eat, and also an additional factor is distension, were the ones who had a higher proportion of these porphyromonas and enterobacteria. I don't know the exact names for some enterobacteria within the family of E. coli. So maybe there could be very interesting to correct this problem. In this study that hasn't been finished, we see that the wall and the small bowel is injured or altered for the excess of this bacteria. And besides having an intestinal pain after each meal, they're affecting permeability, and they are transmitting toxic substances into the blood that may have a relationship with the cognitive disorder. We still don't know. We are just speculating about it. So it's one of these diseases with the epidemiological partner is parallel to the Crohn disease, allergies, multiple sclerosis, are the diseases that start on the second half of last century. I would like to complement the information. There are some studies that say that autistic patients have a lack of the serotonin gene, and we know the role serotonin plays in our body, in the central system as a neurotransmitter modulating empathy and different actions, and in the gastrointestinal tract, in the nervous system. Thank you very much for your attendance.